Welcome back to the Neurology 101 series here on the ProPA podcast. I'm Dr. G, and today we're diving into epidural hematomas, a must-know topic for any provider handling trauma or altered mental status. It's a fast-developing condition that's easy to miss if you don't recognize the early signs. Let's get into it. Did you know, although rare, epidural hematomas can be rapidly fatal? They're most common in young males following head trauma and are classically associated with temporal bone fractures and a tear in the middle meningeal artery. Let's look at the kinder patho. What is an epidural hematoma? An epidural hematoma is bleeding between the inner skull and the dura mater. It's usually due to an arterial rupture, often the middle meningeal artery, following blunt trauma to the temporal region. I always remember the middle meningeal artery as the MMA, and I think of an MMA fighter getting punched in the temporal region. Blood collects quickly under the arterial pressure, compressing the brain structures. The classic scenario: a patient with a brief loss of consciousness, followed by a lucid interval, then rapid deterioration. Let's look at the clinical presentation. Some of the key findings include blunt head trauma, especially to the temporal area, a brief loss of consciousness followed by a lucid interval, followed by rapid neurologic decline. Some patients also have a headache, vomiting, and confusion. Seizures and focal neurodeficits can also be found. On exam, we might see fixed and dilated pupils, usually ipsilateral. Signs of herniation if not treated urgently. So how do we diagnose this? Well, first we want to get a non-contrast CT scan. This is our first-line imaging of choice. A classic finding is going to be that biconvex or lens shape hyperdensity that does not cross the suture lines. This distinguishes it from a subdural hematoma, which are usually crescent shape and can cross the sutures. So how do we treat epidural hematomas? Well, it is an emergency, and we want to emergently consult a neurosurgical team. A craniotomy can be used to evacuate the hematoma and control the bleeding. Initially, we want to stabilize our patient with the ABCs. We want to elevate the head of the bed, consider giving osmotic agents like mannitol or hypertonic saline to control ICP, and reverse anticoagulation if applicable. Time is brain. Don't delay definitive care. All right, book med versus street med. So the book's going to tell us a CT that's going to show a lens-shaped bleed after trauma. Neurosurgery is called, and the patient does okay. Street med: 17-year-old gets hit in the head during a football game. He's dazed, but talking. 30 minutes later, he's totally unresponsive in the ER, pupils blown. You race the clock to get imaging and call neurosurgery. Some quick clinical pearls. The lucid interval is key. Don't be reassured by talk and die patients. Fixed dilated pupil often indicates uncal herniation. Arterial bleeds develop faster than venous ones. Epidural hematomas are surgical emergencies. And watch closely even if the initial CT appears small. All right, let's practice our knowledge with some PANCE style practice questions. A 19-year-old male presents after blunt head trauma. He briefly lost consciousness, then became alert, and is now rapidly deteriorating. CT shows a biconvex hyperdensity. What vessel is most likely involved? Is it A, the bridging veins, B, middle cerebral artery, C, middle meningeal artery, or D, basilar artery? If you said C, you are correct. It is the middle meningeal artery. This arterial bleed from the MMA is the classic cause of an epidural hematoma. Which imaging feature best distinguishes epidural from subdural hematoma? Is it A, a midline shift, B, hyperdensity, C, crescent shape, or D, lens shape? I'll give you a few seconds. The answer is D, lens shape. Epidural hematomas appear as biconvex or lens-shaped collections on a CT. They do not cross the suture lines. All right, some final thoughts. Epidural hematomas demand speed and suspicion. Just because the patient looks fine after head trauma doesn't mean that they are. Don't miss the lucid interval. It's your early warning sign. Next up, we'll cover subdural hematoma, the slower but equally dangerous cousin of this condition. If this episode helped you visualize that CT scan or remember that MMA, share it with your classmates or EM buddies. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you soon.